So I want to welcome everybody to the fifth and also final event in the Center for Human Rights Research Critical Conversation Series for 2024. My name's Adele Perry, and I'm a settler scholar here at the University of Manitoba. I teach in history and women's and gender studies, and I also direct the Center for Human Rights Research. We're all based here at the Fort Garry campus, territories of the Anishinaabe, Innu, and Métis people, bound by the agreements and relation of both Treaty 1 and the Manitoba Act. Our drinking water comes from Treaty 3 to the east, and most of our hydroelectric power from Treaty 5 to the west and north. And we're mindful of the request of the families of Mercedes Myron, Morgan Harris, and Mishkote Bizikwe that land acknowledgements mean little until Winnipeg's landfill is finally searched. And it is here that we do the work of coordinating and promoting research that's concerned with human rights, broadly defined. Since 2012, which was some time ago, the center has held an annual seminar series open to the public. During the pandemic, we went online, and this is the first year we have been back fully IRL, and it has been lots of fun. Our research theme, our theme of our series this year, pulls on one of our research themes, which is on sexual and reproductive rights, and both broadens it and sharpens it to look at the connections between histories of the body, of reproduction, and care in the Canadian context. And as we've often done, this is run in conjunction with a course, in this case, History 4000-7772. And I will say, since it's our last public seminar, it's been great to work with a group of students in this course. And we are currently working on an annotated bibliography that we are kind of producing that will be up out in the world maybe in another couple of months. You should keep your eyes open for that. I'll also say that I have a sign-in sheet for the students from Social Work 2000. And I'm going to pass that around. If you could just write down your name and your email, that would be outstanding. All of this is possible because of the work of Dr. Pauline Tennant, Denise McInnes, and Angela Ciceron from the CHRR. We also received additional funding from the Women's and Gender Studies program through the Margaret Lawrence Endowment Fund. And throughout this entire series, we've really benefited from the hospitality and good coffee of the folks at St. John's College, and also from the expertise of our colleagues at Media Services, who have made it possible, one, that we can have recordings, but also that we can be heard, because that doesn't always work out as well as it should. But it's especially fitting that we end this series, with somebody who is from our research community here at the University of Manitoba and the Center for Human Rights Research. Dr. Lindsay Larios holds a PhD in political science from Concordia University, and has taught in the Faculty of Social Work at the University of Manitoba since 2020-ish? 21, yeah. Yes. She is an interdisciplinary critical policy researcher with a focus on citizenship and immigration and its relationship to the politics of reproduction. Her work demands that we see precarious migration as an issue of reproductive justice. She's also a research affiliate of the Center for Human Rights Research and part of our Period Inequality and Justice group. Lindsay's talk today will be on migrant reproductive justice, perinatal and abortion care with precarious immigration status. And I will turn things over to Lindsay and just say how grateful we are for all y'all for showing up and being here, and for Lindsay for making time for doing this at what's kind of a busy time of the year when we're hoping spring finally comes. And it's a lot to ask people to gather in these moments, but maybe perhaps especially important that we do so. So I will turn things over to Dr. Larios.
Great. Good afternoon, everyone. Thank you, Adele, for that lovely introduction. Thank you, Pauline, Angela, all the folks at the Center for Human Rights Research, for everything you've done putting together this amazing series this semester. I've so enjoyed coming to these talks, and I'm truly honored to be invited to be part of it and to join that list of really wonderful peer speakers we've had as part of this seminar, this semester. So today I'm going to talk about largely my more recent work on healthcare access or reproductive care access for the folks without health insurance living in Manitoba. In some ways, this is a preliminary findings kind of presentation in that we just wrapped up data collection in December. So I'm hoping to be able to speak broadly to some of the themes we've seen, and hoping that you can think about places where you've seen some of these issues emerge in your own work, in your own communities, and how we can move forward to address these as a community together. And in doing so, I'll also draw a little bit on my other work from different projects across Canada working on similar issues to kind of tie together some of the policy threads that I see here. But before I do that, I want to begin this talk with a brief reflection on my own positionality and how this informs my understanding of my work, my obligations as a researcher, as an instructor, as a community member, and as a citizen. So I'm a descendant of Mennonite and Scottish settlers who came to the lands of the Anishinaabe, Assiniboine, Dakota, and Cree peoples and settled on the homeland of the Métis Nation. Manitoba author Sarah Enns refers to these Mennonite communities as a people displaced, displacing. And this is a turn of phrase that really resonated with me as I was putting together this presentation, what it meant to immigrate to Manitoba, to give birth in Manitoba, and what that's meant since we first had an immigration regime that came to regulate that. And so for me, when I think about that phrase, a people displaced, displacing, I reflect on a family and a community history marked by violence and imperialism, revolution in Russia and the USSR, as well as the privilege of European settlerhood and the eventual citizenship under the colonial state of Canada that I currently hold, provided at the expense of Indigenous communities and nations. So I have the passport of my great-grandfather that he was issued when he and my great-grandmother immigrated from Russia to Canada. And it's marked with the languages of imperialism: Russian, French, English, the authoritative stamps that indicate the crossing of a border, the colonial authority of the Canadian government, the whiteness and Europeanness that made each of these crossings possible, the ableism of the medical checks, the confirmations from home communities that these families would not become public charges of the state, the patriarchy, the invisibility of my great-grandmother in almost all immigration documents. So my great-grandparents arrived in Manitoba in September 1925. A month later, gave birth to their firstborn child. So my great-grandmother spent her whole pregnancy moving across borders, yet also invisible. So I don't tell this story to make any kind of equivocations between my great-grandmother's experience and what we see happening in our migrant communities now, but I do think it's helpful to ground these experiences in the histories of immigration, the histories of imperialism and colonialism that ultimately shape what our current immigration, citizenship, and border regimes look like now. So I tell this story, one, to underscore that pregnant people have always been mobile and migrating, even if not documented, not part of those historical narratives. Two, to position the global structural phenomenon like imperialism, like colonialism, and their enduring impacts as inseparable from our current immigration, citizenship, and border regimes, and putting them at the forefront of our thinking of Canada as a settler state. And three, as a way to focus the responsibilities I have with the privileges of citizenship that I carry to do the work of challenging these deeply violent components of our immigration, citizenship, and border regimes for both migrant and Indigenous communities, and to work creatively and openly to reimagine and support communities of care such that the protection of human rights of one group does not come at the expense of another. So also important to acknowledge is that my great-grandmother was an invisible pregnant body because she was a white European. Racialized and gendered logics of colonialism meant that at the same time as my great-grandparents were arriving in Canada, Canada also had immigration policies that explicitly denied entry to racialized migrants and their families. And when they did accept folks, it was a matter of labor extraction. So we have several kind of examples that we can point to, though there are many. But if we think broadly to Chinese labor migrants who were recruited to build the National Railroad, but were barred from bringing their families, their wives, from developing intimate relationships in their communities here, and establishing families here in Canada. With Asian women in general, broadly characterizing as having this corrupting sexual influence on Canadian communities. This is part of our immigration system. And we can also, another example, point to the legacies of, say, domestic workers coming from the Caribbean. Again, barred from bringing with them their families and closely surveilled in their workplaces, in their homes, while at the same time, young European women being recruited as mothers of the nation. So scholars of reproduction have long noted, as Stettner is quoted here, the regulation of women's bodies reflected dominant beliefs about who should and should not be encouraged to procreate, and by extension, about which people were valuable as citizens. And I think, although Stettner here is speaking to a very specific current contemporary context, we can see the ways in which this kind of thinking around who belongs in Canada and why, who's permitted to cross these borders and under what conditions, is really shaped by these same values of imperialism and colonialism. So what does this mean for us now? What does this look like now? In contemporary migration, we see consistently that pregnant migrant women are constructed as, one, a threat to Canadian citizenship, so discourses like anchor babies, birth tourism, welfare queens, frequently being ascribed to racialized women in particular, but racialized people more broadly when they migrate, especially with precarious status. Pregnant people is not requiring or deserving access to basic public services and resources like healthcare, daycare. Those components of our social welfare state that we've put in place to kind of address some of the gender inequality within our society are inaccessible to a lot of folks who are positioned as undeserving. And they're also characterized frequently as having high medical needs. So we think of stories that, well, these are expensive patients, these are going to be costly patients, who's going to pay for that? And having that be the priority in considering who's going to have access to healthcare and what that's going to look like for those folks. So we see this kind of narrative consistently throughout our politics, throughout our discourse. Even though Winnipeg is a really small city and international airport, not so much, it's still alive and well in our hospitals, in our health systems. And so I think part of the work I'm going to do today, hopefully, is to unpack that a little bit. And so what's interesting is that on the backdrop of all of this history of what immigration has meant in Canada and what's that meant for different people, is that we also have this way of talking about gender equality and feminism within our current governments that is reassuring and gender-based and equity-focused. And so it's a conundrum in a way. We have groups of people who are living in our communities, active in our communities, working, but who still cannot access those basic things like healthcare. So these policies, discourses create conditions where pregnant people put off accessing care, which in some circumstances, as medical and public health research has demonstrated, can have really serious long-term risks and health consequences. So All of this, despite the fact that Canada has made reproductive rights, maternal health, and made reproductive rights and maternal health national and international priorities. So we see Trudeau's statement here, all women, no matter where they live, should have access to safe quality health care they need. And by investing in sexual and reproductive rights and maternal, newborn, and child health, we can build a more just and equal and prosperous world. Canada also plays a key role globally in forwarding a gender-based perspective in migration. So advocating for gender-responsive migration policies that promote and protect the human rights, including access to service of migrant women and gender-diverse folks. So broadly speaking, Canada has a relatively liberal, stable, pro-choice reproductive and maternal health policy regime that has generally moved towards rights expansion. However, while we advocate for a gender analysis of migration, we continue to enthusiastically kind of pursue an immigration regime that introduces structural discursive barriers to reproductive rights and maternal well-being of migrants in Canada. So in this context, where reproductive rights are ostensibly framed under the right to choose, a lot of the questions I ask in my work really are grounded in this idea of what does it mean to the state when a migrant pregnant person chooses? What choices do they have? What does it mean when a migrant pregnant person chooses in a way that doesn't fit the prerogatives of the state? When an international student becomes pregnant, what opportunities do they have for reproductive self-determination? A temporary worker, or a person without status at all. And so, thinking about those questions, I come to this work through the lens of reproductive justice. So I really build on the reproductive justice activism and related scholarly work of racialized and otherwise marginalized women in the US, specifically the theoretical work of activist and scholar Loretta Ross. I ground my analysis in this issue of reproductive justice, which enables an analysis that from the start defines pregnancy and childbirth as a matter of justice, not merely a health issue or a legal issue. So the definition I like, there's lots of definitions of reproductive justice and ways to talk about it, but the one I'm most drawn to is from Sister Love, which defines reproductive justice as the conditions of liberation that will exist when all people have the power and resources necessary to make their own decisions about their bodies, health, gender, sexuality, relationships, families, and communities, to create and choose their families, to reproduce their communities as a whole, all with dignity, self-determination, and genuine support. So what that tends to break down to, in simply speaking, is three basic principles, each grounded in ideas or beliefs around bodily autonomy. The right to have children if you want to have them, the right to not have children if you don't, and the right to parent children in safe and healthy environments. So when we look at immigration, the ways in which this system opens doors and closes doors for folks can either expand reproductive possibilities or close them, and often does both at the same time. Thinking about Canadian migration, since the mid-2000s, Canada has accepted more people into its borders on a temporary basis than for permanent settlement, and has rapidly developed an increasingly complex labyrinth of temporary migration programs, as we see kind of listed on the side there. So as a result, there's an increasing number of people whose residency in Canada is contingent and relatively unstable, and whose access to basic services may be restricted, putting them in a position of relative precarity compared to Canadian citizens and permanent residents. So this includes people who may have entered Canada as migrant workers, international students, as visitors or asylum seekers. And broadly speaking, we refer to these forms of migration as having precarious immigration status. So this includes both authorized and unauthorized forms of non-citizenship that are institutionally produced through Canadian immigration policies, procedures, and that each share a precarity rooted in the conditionality of presence and access. So we think of two dimensions that are key to conceptualizing precarious immigration status. So conditionality of presence. So often when we think about these or look at these groups, they're each provided, perhaps in some cases with the exception of people without formal status, with a temporary resident visa. This visa dictates how long you can reside in Canada and under what conditions. It is conditional. It's fully dependent on meeting the requirements of that immigration program and the interpretation of your reason for being in the country by the system. And we also talk about conditionality of access. So what resources, services, opportunities, entitlements can you access? With your visa, do you have access to healthcare, daycare? Can you work? Can you go to school? All of these components of our everyday life that as citizens or permanent residents, we can access largely without thinking about it too much, though, I mean, I don't want to overstate the robustness of our social welfare system, but without thinking about what it would mean to us if we couldn't. And so we have a growing number of folks who are in our communities who are living in this kind of state of precarity. And important for our questions here today around reproductive health, perinatal care, and abortion, roughly half of these entrants identify as female, and the majority of those are characterized as being of childbearing age. So this is a large percentage of people who are likely have families, want to start families, or become pregnant for any number of reasons. So just to, I guess, give a sense of what this looks like in terms of healthcare. So the project in Manitoba that we're currently doing now focuses specifically on access to healthcare. We're talking to folks who are medically uninsured or underinsured. So for the purposes of today, I just want to break that down so you have a sense of who that is and what that looks like. So when I talk about temporary workers, there's lots of ways you can get a work permit, different programs. And the length of your permit and what it is, what kind of job you're doing, will dictate whether you can access Manitoba Health Services or not. So for example, if you have a work permit that's over or that's under 12 months, you're not going to be able to access healthcare. There's also a 3-month wait period, so a bit of a probationary period, where you're not going to be able to access public health care. And so most folks in that situation must purchase or rely on private health insurance. This often requires a copay, so you're paying up front for at least part of your services, and it's not always comprehensive. And this includes not only yourself, but also perhaps your family members that you're bringing with you if you're able to do that. So we can also think about international students, which is a big population at U of M, certainly, and in Winnipeg and Manitoba in general. Since 2018, this whole group and their dependents must rely on private coverage. We have the same issue there. Copay is required, and it's not always comprehensive. Refugee claimants are also here temporarily with a temporary visa unless their claim is approved. So they are covered under the Interim Federal Health Program, not our provincial services. And if their claim gets refused and they stick around to try to appeal it, then they will no longer have access to also that federal program. There are also a range of just other temporary residents here visiting family, maybe awaiting family sponsorship, that must require private coverage. And then folks in general who don't have status. And so these are people in Canada, it's most likely that they had status, fell into one of these other categories at some point and no longer do, and can now no longer access neither the public or the private system. So being medically insured can look very different for a wide variety of reasons, depending on your immigration trajectory, who you have with you in your family, your work life, and your ability and patience and luck in terms of getting all of these documents renewed and processed in an adequate way. So also important to note that when you have precarious status, even having public health care insurance can be precarious. So your eligibility for health care insurance is always going to be tied to your immigration visa. Any lag or disruption in visa renewal also means a lapse in health care coverage. So whether this is a mistake made by an immigration official, by IRCC, or yourself on your application, it's going to be a lag in your processing of your documents. It can also be really disrupted by life situations like pregnancy or illness, where all of a sudden you can't stay at U of M and study because you have a chronic illness or you're pregnant and you're on bed rest. And what does that mean if your visa renewal comes up? And so access in general is subject to change in accordance with political will. So thinking back to 2012, the federal government took away refugee claimant healthcare, and then it was reinstated again in 2015. But that's 3 years where a whole group of people who were here fleeing violence could not access healthcare. It's a political issue. Manitoba health services were extended to agricultural workers with work permits less than 12 months in 2012. So that's a win, or sorry, 2013, that's a win. But then 5 years later, we see it removed from international students. RAMQ, which is the Quebec public health insurance, recently extended to all children regardless of status. That's a huge win. And then if we look over to Ontario, we can see that their public health insurance was extended to everybody during the pandemic, but then removed just a couple of years later. So even for groups that have eligibility tied to their immigration documents here, their visa here, this is subject to change. This is still precarious. And then, of course, the kind of the response I often get from policymakers in particular is like, well, they have private insurance, they're fine. But there's precarity in private insurance too. So again, there's eligibility criteria. You have to have that consistent immigration status. So if there's a lag, it's going to affect your public health care. And it's just not an option for people without status at all. It's also really expensive. Costs can be prohibitive. It makes people take a plan that is less comprehensive, doesn't cover as much. And often these plans still require you to pay up front. So it's great if you're going to be reimbursed, but you still need to pay that $1,000 at the hospital, and what are you going to do? So they're not comprehensive, and they often don't cover pre-existing conditions. And then, of course, there's the precarity of no health insurance. So in Canada, because doctors have a duty to care, technically, if you show up in an emergency room and they assess you as needing care, they have to care for you. But ultimately, it's the doctors who define whether you need care or not. It's not your choice. And you're going to be billed for it. For non-emergency care, you have to find a doctor willing to provide care on a private basis so you can pay those costs directly. And there's lots of barriers to that. So difficulties finding doctors, navigating the system, the costs, and fear of the system in general. Fear that maybe they'll give your information to border authorities, CBSA, or just not understand the precarity of your circumstances. So that's the really technical overview of what that landscape looks like in terms of access to healthcare if you don't have permanent residency. So now I'm going to kind of shift and talk, or see if I can ground some of that in some lived experience from the research. So this is a project, like I said, we've been doing data collection during 2023. We've interviewed 20 community, social, and health service providers, and 10 people with lived experience, talking about what it was like to access reproductive health care in Manitoba while not having access to Manitoba Health. And so I'm going to kind of walk you through Lydia's story. So Lydia was an international student studying in Winnipeg, and participated in our project, obviously. So Lydia graduated in 2020 and applied for a postgraduate work permit. So for folks who aren't familiar, when you're an international student, you get a study permit, and once you graduate, you can get this work permit that allows you to kind of work in Canada for a bit longer and eventually get permanent residency if it all works out. So she graduated, applied for her work permit. However, due to processing delays, probably exacerbated by the pandemic and all the craziness that was 2020, she found herself without health insurance at the beginning of 2021. So in a normal situation, she probably would have been okay, but it just so happened that she was pregnant at the time. So in between that time, between graduating and and waiting for her postgraduate work permit, she was pregnant and was trying to scramble and figure out, are these immigration documents, are these health documents going to arrive by the time this baby arrives? And if not, what am I going to do? And so this is a really consistent problem throughout our immigration system, is that there are constant delays in processing and that lead to all kinds of barriers for folks. So on one hand, these extended processing times often mean there's a gap between your permits and therefore a gap in your health coverage. And this can end up leading also to shorter work permits. So the way this looks, that again, this is a bit of a technical detail, is that you can apply for a 12-month work permit, but if there's a delay in processing and you get it 1 month late, they're going to give you an 11-month permit, and then you're not eligible. So all of these kind of technical issues add up to really creating these situations where people don't have a lot of options. And so in Lydia's case, she was a student. We see this with students, but consistent narratives for workers, also for refugee claimants who are just stuck waiting for documents to be processed. So it's not that they're ineligible, they are. It's that our system is fundamentally letting them down. And yeah, worth noting, in Manitoba, we have a 12-month requirement for a work permit, then you're eligible. In a lot of other provinces, it's 6. So there are also these small details within our system that just put people back, right, that could be changed. So initially, Lydia sought to terminate the pregnancy. It was unplanned. She was just graduating, trying to stabilize herself within Winnipeg, and really not looking to have another child at this point. But when she went to the hospital to try to terminate the pregnancy, she was ultimately turned away. And so this could be for different reasons, but her interpretation of this was it was because of her immigration status. And so during the pandemic, HSC, which is one of our health science center, which is one of 2 locations in Winnipeg where you can get an abortion, was turning away people without health insurance because they were understaffed. And so this meant that she was referred to a community health clinic, so Women's Health Clinic, which is the other location. However, as all things in the pandemic, there was long waits, and by the time she finally got her appointment, she was no longer felt like she wanted to have the abortion. She had developed an attachment to that child because she had waited so long. And so this kind of speaks to another theme that we see, is that folks with precarious status have restricted access to services and have fewer options overall. So abortion services is one of those. So it can be limited for people without public insurance in different ways. Sometimes your private health plan doesn't cover it. And sometimes the costs at the hospital are prohibitive. So getting a procedural abortion at Health Science Center can range between $5,000 to $10,000, which is a little bit ridiculous. But if you go to the clinic, they're going to cap it at $500. But there's a huge difference between those costs. And how are you supposed to know that? What does that look like when you're actually in that situation, feeling vulnerable, needing care, and that's the kind of bill that you're facing? There are also lots of ways that access is restricted for perinatal and prenatal care. So one striking example in the Winnipeg context is that midwifery services aren't available to folks without public health insurance in Winnipeg. If you go to Brandon, it's fine. You go to Winkler, go for it, but not in Winnipeg. Again, how are you supposed to know that? And what if, for any number of reasons, you feel like midwifery care is the best for you? Why do we do this? Why is this policy here? So for Lydia, her child arrived prematurely. So she was faced a range of different medical risks. That meant that she delivered early, she had to be hospitalized early, and delivered via C-section. So all of this happened before her immigration and health documents were processed and arrived. As a result, she received a bill totaling almost 40 grand. And this is a substantial amount of money, but it's not a surprising amount of money, given kind of the accounts that we've been hearing that people are encountering in our hospitals. So across the board, across the country, these kinds of out-of-pocket expenses and bills are by far the biggest barrier to accessing care. And it means people are constantly putting off care and trying to figure out how else they can self-manage any medical issue they're facing, including pregnancy. I think there's another one here. Yeah. So deposits for delivery in Winnipeg are astronomical. So what this actually means, you can get your prenatal care with your doctor, pay for each appointment. But when it comes to your 3rd trimester, the hospital will ask for a deposit because they want to know that whatever costs you accrue giving birth, you are going to pay them. So they ask for deposits of 25 to 30 grand, which is something that nobody can pay because, like, we're talking about students. We're talking about migrant workers who are coming to work low-paid jobs. And so that means in the 3rd trimester, when people need care the most, there's the biggest barrier. And this practice is pretty normal across Canada, but these amounts are higher than other places that I've encountered. So Montreal, on average, 11,000 is what places are asking for. You can go to certain hospitals strategically, maybe get 6,000 deposit. That's a good day. But it's it's prohibitive, right? It's a disincentive to give birth here. On top of that, none of those fees that you're paying for your doctor's appointments, for your hospital bed, are going to include lab tests, ultrasounds. Those are all additional costs. And catching COVID in hospital or any other complications, either for yourself or baby, exacerbates those expenses, of course, right? So each day someone's in hospital is about $2,500, and then the additional fees for the actual care you're receiving. And common practice by hospital finance offices is to offload these bills to collection agencies. So you get home with your newborn, you haven't slept, and you start getting harassed by a collections agency. So we know for sure, based on other data, that people without health insurance are not accessing the prenatal care they need. They're not coming to hospital when they're at risk. And what folks end up doing is just presenting in emergency rooms when they're in active labor. So that means that any kind of preventative care that could have been done to maybe mitigate some of those costs or some of those health risks is probably not going to be done. So all of those hospital bills are Lydia's. Lydia's partner is a Canadian citizen, so this means that citizenship and health documents for her baby is pretty straightforward. Just the regular delay that we all experience with Manitoba Health. However, that's not the case for everyone, right? It's a really complicated bureaucratic process if a parent isn't a permanent resident or a citizen. The kinds of documents you need to provide, proof of residency, how long you're going to stay there, all of those kinds of things in order to get health care for this Canadian citizen baby. And there's also really inconsistent implementation. A lot of folks in hospitals don't seem to know who's eligible and who's not. So we have instances where mothers are told, oh, you're just a visitor, your baby doesn't get health care. Well, she does. So again, how do you know this if you haven't looked into it? So we're seeing a concern not only for the pregnant people, the people giving birth, but also children who are maybe falling through the cracks as well. So due to having this large bill that she couldn't pay right away, Lydia's information was shared with Border Services, so the Canadian Border Service Agency, by the hospital finance department. And she was obligated to report to border authorities. So what we've uncovered kind of through our data collection and talking with different folks is that reporting and threats of reporting to CBSA are unfortunately pretty common within hospitals in Winnipeg. And conversations with WHR indicate that they regularly communicate with CBSA regarding people with high medical needs and high expenses. So threats from hospital finance departments, and there's also threats, from hospital finance departments that they will involve CBSA if you do not pay your bill. So this has become an increasingly regular practice. We see it a lot with international students, where it's fear, right? So now, not only are we scared of the bill, but we're also scared that maybe our immigration case will get reported, and even if we're there totally legally, it will somehow impact our immigration moving forward. And it's scary. CBSA is a law enforcement institute. They can detain you. They can deport you. So any kind of interaction with them is a major mental health kind of trauma-triggering situation, and we know this. So another issue that we're seeing kind of come up in the Winnipeg context. And so one of the questions we always ask folks in our interviews with them, in conversations with them, is to kind of explain, like, well, this is what reproductive justice means to us. What does it mean to you? Do you think, does that resonate with your experience? And what Lydia said is, I don't think I had those freedoms or those rights. I didn't feel safe. And reflecting on her story, I think it's pretty clear. All the instances where her autonomy, her ability to make choices the way she wanted for her family, were really constrained by a process that was totally out of her control. So that's all like super depressing. And it sucks. And there's like no other way to say it. We have a system that's fundamentally not made to accommodate the health needs of a huge portion of our population. So what do we do? And there are things we can do, is kind of where I want to end off on. There's advocacy actions we can do. There are policy changes we can push for. So first off, broadly speaking, we need a recognition that temporary migration programs produce structural vulnerability, and we need to move away from this kind of migration regime. And I don't mean capping the numbers of international students or workers. I mean, and not just me, the migrant advocacy community means regularization and access to permanent residency. So by regularization, we mean the implementation of a program where folks with, in a precarious state or with no status have a pathway to permanent residency. Sorry, back to my notes. So in the December 2021 mandate letter for our Minister of Immigration, at the time this was Sean Fraser, he was told to explore ways of regularizing status for undocumented workers who are contributing to Canadian communities, and to make more pathways for permanent residence for international students and temporary foreign workers. Since then, many community and advocacy groups like Migrant Rights Network, Canadian Centre for Refugees, as well as professional bodies like the Canadian Bar Association, have participated in consultations with government. At the same time as all of this is happening, our federal government has spent an increasing amount on deportations for a total of, say, $111 million in the last 2 years. So on one hand, we want to regularize folks, and on the other hand, we're going to deport them. Just a few weeks ago, the Migrant Rights Network had held numerous demonstrations across Canada in various different cities, drawing attention to the lack of movement on regularization and these seemingly contradictory policy moves. So that's kind of the coverage you see here. One from Montreal, the Migrant Spring, and then there was a Winnipeg rally a few months earlier in September, where we gathered together and made the same kind of claims. So if this is an issue we care about, then participating in demonstrations like this, writing letters to those folks whose job it is to implement these programs, because it says in that letter that's what they're supposed to be doing, those are all things we can do. We can apply that pressure if this is important to us as community members, as citizens. There are concrete things we can do to hold these folks accountable. Secondly, we need to recognize the harm of restricting access to health and social services based on immigration status and open up access. So my research, as well as that of numerous scholars and just people on the ground who have been navigating these issues every day, we know that these restrictions produce gaps in vital service provision and human rights, as well as produce discourses of deservingness that can negatively impact pregnant migrants' interactions with healthcare providers and their broader communities. So like regularization, there has been a lot of organizing efforts across Canada that push for expanded eligibility to healthcare insurance. And in Manitoba, ongoing efforts by community health clinics and groups like Migrant Manitoba, Immigration, IWP, maybe there, and folks in the community who do this work every day and are raising these issues every day. So after 2018, the year that international students lost access to their healthcare, a number of organizations, as well as unions, students, and other allies, came together under the umbrella of Healthcare for All Coalition Manitoba. For the last 5 or 6 years, pushing for the expansion of healthcare access in Manitoba to all, but specifically to reinstate it for international students. So that's the advocacy work that you see pictured there. So included in the mandate letter for the current Minister of Higher Education is a province to reinstate healthcare for international students. Yet, we see no commitment in the provincial budget, and I'm making a bit of a leap there because it's not actually released until this afternoon, but if someone knows something I don't, please let me know. But we see no commitment in the provincial budget to make this happen this year. So, again, advocates are participating, are calling for meetings, are demonstrating, are holding campaigns to try to hold governments accountable. And these are all things that you can get involved in if you want to. So we currently are still doing our healthcare, or Show International Students Some Love healthcare campaign, signing postcards, sending them to the ministers. But you can also write a letter, call your provincial MLA, participate in the process and hold folks accountable. Thirdly, implementing conditions such that all community members can access care they need without fear of deportation, debt, or discrimination. So access to without fear policies, or sanctuary city policies, if you're maybe more familiar with that term, is an approach to providing service provision that makes a commitment to not ask about immigration status, and if you find out immigration status, not share it with anybody. So we have an Access Without Fear movement in Winnipeg who has engaged with our city councillors, with various provincial members of the Legislative Assembly to try to move forward on this issue. We know that other provinces have made progress on this issue. So the health privacy legislation in Ontario means that healthcare providers cannot legally share that information with CBSA. We don't have that here. Individual health jurisdictions in BC have done their own advocacy, which is what you see in the image, Hospitals Are Not Border Checkpoints. This is from the Sanctuary Health movement in BC, where they've worked with individual health authorities to put in Access Without Fear policies. Overall, these make a huge difference in people's sense of security going into healthcare spaces, and increases the likelihood that people will have positive experiences with healthcare and be able to form relationships with healthcare providers. And again, I can talk to political will and all of those things. Most of you know me as the policy advocacy instructor, so you've heard my spiel before. But there's also things you can do in your own individual organizations. So these can be organizational level policies, right? Where we decide as an organization, as a clinic, that this is a practice we're not going to engage in. So there are very simple policies you can implement within your own community now that can help address some of these issues. And lastly, more broadly speaking, probably the normalization of the pregnant migrant body and the role of migration as a component of bodily autonomy, which I link to this call to action for feminist reproductive rights and women's health movements, which are pretty strong in Canada overall, have a really rich history, to join the cause for migrant justice. So we can't have a truly intersectional feminist movement without taking into consideration the way that citizenship, borders, and our immigration regime impact these things. And so in doing our in doing work around reproductive rights, reproductive health, this has to be part of the conversation. So there are organizations that are doing this really well, but not a lot, unfortunately. Action Canada speaks about immigration status all the time. So Action Canada is a national level abortion, sexual reproductive health education organization. And they explicitly tie their ability to do their work to people's access to care. There's the example here at the bottom of, in French, is a report put out by a families organization that doesn't have anything to do with immigration, but how do we support families in our communities better, meant for them having to take immigration into account. And part of the work they did in collaboration with folks from migrant justice communities is to help introduce that recent policy we saw in 2021 in Quebec that allowed for all children, regardless of status, to have access to healthcare. And so what I encourage researchers, folks in community involved in reproductive health work, families work, working in schools, child welfare, think about immigration status. Factor that in to your understanding of the issue. And so one example I also have here is, and this is low-key a pitch to a new project, what is it like to access abortion in Manitoba? This is a project we just launched that explicitly asks about, did your public health, or did your health insurance cover it? Because we know how that's going to shape access, right? We know that's part of an intersectional analysis. So I think I'll leave it there. Thank you all for your attention. And I'm happy to, answer any questions. Also, just want to take a moment to acknowledge research assistance for this project from Patricia Hanon, Heidi Elias, who's here with us today, Victoria Weir, Sarah Gibson, and Nosha Tabassum-Urmi. And this research also received funding from CHRRR Manitoba, and we have a community partner, or CHRRR Manitoba, Canada, and community partner Manso. So I just wanted to shout out to those folks.